Today we're going to cover a quick history and just a brief structure of EMS and EMS here in the United States. So let's start with legislative history behind what we're doing, more specifically, what has happened on a federal level. Although we can trace it back much further than this, we'll start in the mid 1960s with what's commonly called the white paper. White papers are just position papers, papers produced by federal agencies. So our white paper, what we call the white paper, in mid 60s, 1966, entitled Accidental Death and Disability. Created or led to the National Highway Traffic Safety Act and really highlighted the need for some sort of structured emergency medical response system. There were numbers and numbers and numbers of people dying in traffic accidents, and that was highlighted in this white paper. So what came out of this was a recommendation to develop an EMS system to address these horrible accidents on the highway. While this white paper and the National Highway Traffic Safety Act was really focused on traffic deaths, paramedics came about a little bit later, a few years later, and we kind of focused our attention on California. Now, this isn't a federal level legislative act, but in California, they were the first ones to legalize paramedics. They weren't necessarily the first ones to have paramedics, but they were the first ones to legally have paramedics. There were paramedics acting or practicing in North Carolina, in Ohio, in Florida, up in Washington, all without legal authority. They're practicing without a license. Luckily, nothing came of that, but California is the first one to move into legal recognition for paramedics. That was the Woodruff-Townsend Act in 1970. A little bit of trivia for you. The then governor, later President Ronald Reagan, was the one who signed that into law in California. Paramedics in California, specifically in Los Angeles, the Woodruff-Townsend Act only allowed paramedic practice in Los Angeles County. They didn't name them by name, but said any county with more than, I think it was 10 million people. And Los Angeles County was the only county that met that stipulation. So paramedics in Los Angeles and the Woodruff-Townsend Act spurred this TV show premiering in 1972. Emergency. If you haven't seen it, go out and track it down. I noticed it on one of our streaming services, either Netflix or Amazon. It's on there somewhere, so go track it down. Go watch a few episodes. It's a lot of fun. If you ever hear of Johnny and Roy, that's where this is coming from. Is this TV show Emergency? This TV show is kind of anecdotally credited with spreading the idea of paramedics across the country. So really influential, even though it wasn't a legal act, a legislative act, really influential. Another little piece of trivia for you, their pilot episode was a Wadsworth-Townsend Act. They actually misspelled the legislative bill. It was Wedworth, not Wedsworth, which is a little fun. And if you get tripped up at trivia night, you've got that to pull out of your pocket. So there was a Woodruff-Townsend Act in 1970 in California, a TV show about paramedics. Came out in 1972, and then in 1973 there was another federal bill, federal legislative act that was passed, the EMS Systems Act. And what this did was establish these regional medical program grants. This would fund programs over the course of 3 years at a total of $160 million, spaced out over those 3 years. And these helped different regions in the U.S. establish paramedic programs. So not just a basic EMS system, which was that white paper set into motion, but these were really paramedic programs and advanced life support programs. And regions around the U.S. didn't have the funds, didn't have the financial ability to just set up these systems. So the EMS Systems Act provided funding to start these systems. These regional grants were refunded and refunded year after year up until about 1980. And then in 1981, as part of the Omnibus Budget Reconciliation Act, these regional grants specifically for paramedic programs, specifically for advanced life support EMS systems, are turned into block grants, and they're administered at the state level at this point, and they were consolidated. So now, if you wanted to apply for one of these grants, before you're applying with another a handful of other potential EMS programs, EMS systems. Now, because they're consolidated, you're applying next to other public health programs, programs for rat traps, programs for syphilis prevention. You're up against those. So it consolidated the grants. A lot of funding was lost because of this Omnibus Act. And another little piece of trivia, in 1970 with that Woodward-Townsend Act, Ronald Reagan signed that into action. In 1981, he was then president and signed this into action. So kind of simultaneously paving the way for paramedics and then pulling federal funding from them about a decade later. The last significant piece of federal legislation, there's been a lot of state level legislation since then, but last significant piece of federal legislation we'll talk about in the history of our EMS systems is the Trauma Care Systems Planning and Developmental Act. Passed in 1990, this established trauma centers and trauma center designations, and that there should be trauma centers, should be places, designated places where we take the most traumatic of our patients. So nowadays we are accustomed to our level 1, level 2, level 3, and so on trauma centers, and we all know where our level 1 trauma centers are. We all know where we're going to take our multi-system trauma patients, but before this, there was no designation. So in 1990, this is what spurred our trauma center designations. Now that we've covered a really quick history of our EMS systems, let's cover our kind of more local EMS systems and ambulance service levels. So we have a scope of practice. We'll have a scope of practice. This is defined by the state, and it's going to differ whether you're in North Carolina, whether you're in Texas, whether you're in California, or anywhere in the U.S. So defined by the state and gives us guidance on clinical treatments, what we can do and what we can't do. So our scope of practice is set by the state and gives us restrictions and guidelines as to our medical authority out in the field. As to our levels of care here in the U.S., we will break them into 4 separate parts, starting with basic life support, or BLS, and then adding a few extra things into our scope of practice, into our intermediate life support, our ILS, and then adding even more into advanced life support, our ALS, and then a handful of other things, a little expanded scope of practice into our specialty care transport, or SCT. This includes our critical care paramedics. At our basic life support level, we think of these as our EMTs, our emergency medical technicians, generally non-invasive. In North Carolina here, they can give a couple IM injections, EpiPens. They can give some nebulized treatments, but generally non-invasive. So basic patient assessment and basic stabilization. At our intermediate level, we've moved up from EMTs to advanced EMTs. Nomenclature-wise, it used to be called EMT intermediates, hence the intermediate life support. These are our advanced EMTs. We've gone from that basic patient assessment and basic stabilization of life functions and added in some invasive procedures. So advanced EMTs in most areas might be able to intubate, might be able to start IVs, and might be able to administer some frontline cardiac arrest medications. At the advanced life support level is when we move into our paramedics, and we have a very full scope of practice. A lot of invasive procedures. we've moved past just the advanced EMT level with a couple invasive procedures and some frontline medications to a whole host of medications. Again, this is going to be dependent on the state in which you practice, but a whole host of medications and a number of other invasive procedures on top of a advanced patient assessment. That fourth level is a specialty care transport level. This is what we think of when we think of critical care and critical care paramedics. We've taken the standard paramedic scope of practice and expanded it to include usually maybe these critical care paramedics can start central lines. Perhaps they can start or place chest tubes, and then they're trained in ventilatory management, mechanical ventilation, trained in invasive monitoring, arterial lines, central venous pressure, things like that. All right, so we've got all of our different levels of care, but we need to respond to a call, whether it's a scene call, whether there's an interfacility call. We need to respond to our call of service. So how do we do that? How do we structure that? We'll think of it in terms of a scene call. Let's say a 911 call. We've got our first responders, and then we've got our ambulance unit responding as part of our EMS system. So our first responders can be either basic life support, BLS, or advanced life support, ALS. So I can have a BLS first response with an ALS ambulance responding and then transporting. It's very common. So you've got a fire department at the BLS level with maybe firefighters cross-trained as EMTs, and then you've got the paramedics showing up in the ambulance. You also have BLS first responders with a BLS ambulance responding as well. Here at Western Carolina University, we have a campus-run EMS service. So we have EMTs on an ambulance. That's a BLS service. So you call 911 here on campus, and the ambulance that's going to show up is BLS. You can also have BLS first response with a BLS ambulance and an ALS intercept. So maybe that that ambulance that responds is a BLS ambulance, and you've got a paramedic in a QRV or a fly car responding if needed. Maybe you've got another ambulance coming. So again, here at WCU, you call 911 on campus, you get the BLS ambulance, and if needed, they'll call in an ALS unit to treat you. We also have ALS first responders. You might have a paramedic on board let's say an engine company. So we can have an ALS first response with an ALS ambulance. I'll point out in York County, South Carolina, not far from here, just south of Charlotte, in Rock Hill Fire Department has paramedics or a paramedic on its engine companies, at least one paramedic on its engine companies. So a paramedic responds as a first responder as part of the fire department, and then the ambulance service that covers that county is an ALS ambulance. So you've got kind of a dual ALS first response and then ambulance responder. And then you can have an ALS first response with a basic life support ambulance. And what I'll point out here is I lived for a little bit of time in Albany, New York. And Albany, their first responders, or the first response, their fire department had a paramedic on its engine company, sometimes a paramedic and then a fire QRV that would respond to a medical 911 call. And then the ambulance that was dispatched was a BLS ambulance for transport. So if we got there, I was on the BLS ambulance. I was an EMT at the time. We got there. If it was a BLS call, we would take it, and the Albany fire paramedic would not go with us. If it was an ALS call, the Albany fire medic would jump on our ambulance with us and ride the patient to the hospital. So we have all these different response structures and response levels. So who are we going to send? And that's kind of up to emergency medical dispatch. It's up to your dispatchers on who to send to this 911 call. And your dispatcher is going to, it typically depends on the dispatch center, but Typically, EMD levels, we have four levels of emergency medical dispatch. We've got Alpha, Bravo, Charlie, and Delta. Some agencies, some systems use a couple extra. We've got Omega, we've got Echo protocols. So what are these? Your Alpha and your Bravos, that's typically a BLS response. Alpha is the lowest level of response. The patient can wait a little bit of time before someone gets there. That's your typical sick call. I haven't been feeling well for a week, and I just want someone to come out and check my blood pressure. So that's a cold response. No lights, no sirens. You can dispatch a BLS unit to that without any problem. Bravos, sometimes hot. Lights and sirens, sometimes cold. Those lights and sirens depends on your system's policies and what they have available to them. Your Charlie and your Deltas are definitely going to be ALS level. Charlies and Deltas are usually both lights and sirens, again, depending on your local protocols. But Charlies are pretty common. That's your chest pain, so your chest pain is going to be a Charlie most often than not. Your Deltas are, this patient will die pretty quickly if you don't get there. So if someone falls off the roof of a building, falls 40 feet onto a concrete pad, that's going to be a Delta response. Your extra little responses, your echoes are the patient is dead right now. In systems that use the echo protocol, these are going to be your cardiac arrests. So your 9 echo 1s are cardiac arrests. They're unconscious, not breathing. So if you're dispatched to an echo level call, you know they are currently unconscious, not breathing, no pulse. Your Omega protocols, they're in the kind of little box in the top left. Our special protocols have been instituted in a few areas here across the country, and those are usually lift assists and calls of that nature where you can send a secondary unit, maybe just a first responder, to go and pick someone up off the floor. So Omega protocols have been tried here and there, and sometimes it's not even EMS that goes. Sometimes an Omega protocol is initiated and they're sent to a nurse on call or someone on call, a helpline to get a prescription refill or to get a physician appointment. Here's an example of an EMD card. This is what your dispatcher is seeing, your call taker is seeing when a 911 call comes in. This is for a signal 10, chest pain. So it's chest pain non-traumatic is your signal 10. Up there in the top left are the questions that the call taker is going to be asking, and it's going to determine the response level. In the top right are some instructions that are going to be given after the ambulance is dispatched to the location. And then there at the bottom, those are your Alpha, Bravo, Charlie, Delta. There is no echo here because if you're actively having chest pain, you're obviously not dead. So if you're unconscious, not breathing, that's going to fit a different EMD code. There's no Bravo here because it's either Alpha and everything's going all right. Just you might have a funny feeling in your chest, and then we're going to skip over Bravo. So there's no Bravo level here in this EMD card. Straight to Charlie or straight to Delta. So what determines Charlie or Delta? Maybe some abnormal breathing, maybe a cardiac history, maybe if the patient or the caller admits to some cocaine use, some drug use, it's going to bump up to Charlie, and then your Delta. So there's the codes there. You see a 10, let's say 10 Charlie 4 or a 10 Delta 1. We can determine as a responder what's kind of going on with that patient. So 10, signal 10, we know it's chest pain. We know Charlie or Delta. If we go with a 10 Delta 1, all of a sudden that 1 means they're not alert anymore. So they were having chest pain and now they're not alert, but they're still breathing, still have a pulse. So that 10 Charlie 4, they are having chest pain. Everything's going all right. They don't have cardiac history and they are they're breathing normally, but maybe breathing just a little bit fast. So this is what your dispatcher is seeing. This is what your call taker is seeing on the dispatch side before and during your dispatch. All right, let's move on to the regulatory environment and regulations and what there is out there and why it's out there. So what's the purpose of all these regulations? So we function under a number of regulations when delivering EMS services. So why? One of those is qualifications. So who should be on an ambulance and what makes them qualified to be on an ambulance and respond to this call. Second are standards. What standards are we upholding? What should we be doing when we are responding to this call? So we have our scope of practice. We have our standards. So I'm qualified to be on that ambulance, and now what should I be doing while on that ambulance and responding to a call? And then finally, oversight. So I should be doing something. Am I doing it? Or am I going outside of my scope of practice? Or is there a case for negligence? So am I qualified to be on the ambulance? What should I be doing while on the ambulance? And then oversight, what am I doing what I should be doing? Those three things provide protection and safety. So protection for the patient, safety of the patient, protection for us as providers, and safety for us as providers. So maybe a pain in the butt sometimes, and a lot of the time, but in the end, at the end of the day, it provides protection and provides safety for not only us, but for those we serve. We have a number of organizations, private organizations out there that accredit and oversee quality of care, quality of service. One of those is CAS, Commission on Accreditation of Ambulance Services. Just like all of these, it's a private organization. In North Carolina, it's not required to be CAS accredited. Across the country, I don't think there's any state that requires CAS accreditation, although it is common. You can go to their website and see if your organization, your agency is CAS accredited, or how many organizations in your area are CAS accredited. Another one is the Commission on Medical Transportation Systems, pretty common in the critical care and air helicopter industry. Another accreditation that again is not required, but favorably seen upon. For educational programs, there's the COAMPS, and this organization accredits educational programs from the medical responder EMT level up through the paramedic level. So if you are COAMPS accredited, or the program you went through is COAMPS accredited, you know you've gone through an accredited program, a quality accredited program. And then the last one I want to point out is the Joint Commission. This is formerly JACO, the Joint Commission on Accreditation for Healthcare Organizations. They are the accreditor for hospitals. And again, just like all these other private organizations, not required but favorably looked upon. And if you work for a hospital-based system, or you're working closely with your hospitals, they're going to get a little up in arms with the Joint Commission, especially when they come around and do site reviews. Regulation at the state level is always handled by some state office of EMS or department of EMS or bureau of EMS. So whatever state you're operating in, providing service in, you're going to be beholden to your state's office. And then there's also the National Registry of EMTs, the NREMT. Most states, the vast majority of states, require that EMS providers be nationally registered through the NREMT. A few don't, including us here in North Carolina. So just a little dichotomy. If we're here in North Carolina, I can get my North Carolina paramedic certification without being nationally registered. If I want to go and work in South Carolina, just across the border, I have to be nationally registered. So it just kind of depends on your state's policy and whether or not they require national registry certification of all your providers. At the federal level, we are beholden to a number of people. One of those is NHTSA, the National Highway Traffic Safety Administration. That's where EMS at the federal level finds itself, is under NHTSA. Um, then we also coordinate with and are responsible to FEMA, the Federal Emergency Management Agency. So when responding to larger events, natural disasters and the such, we'll be operating under FEMA. And then work very closely with the DEA, the Drug Enforcement Agency. All of our ambulances, or all of our, I'll say ALS ambulances and critical care ambulances, are going to have narcotic medications on them. So how are we handling that fentanyl, that morphine, that Versed? So the DEA closely monitors us and our medication handling practices. As EMS providers and agencies and managers are a number of other non-regulatory agencies that we coordinate with, that we work with. Um, we've got the National Association of EMTs, the NAEMT, that works with us at a federal level and as almost a lobbying group, not quite a lobbying group, but represents us at a federal level. We've got the National Association of EMS Physicians, the NAEMSP, a group of EMS medical directors and emergency physicians dedicated to EMS practice. We've got the National Association of EMS Officials, managers out there, usually at the state level, the federal level, that oversee EMS systems across their jurisdictions. We've got the National EMS Management Association. So a group of EMS managers, directors, officers across the country active in their EMS organizations. So that's our quick and brief overview of the U.S. system. But let's kind of dig into, or not really dig into, but look at some international structures. So there are two primary delivery models across the world. One is our Anglo-American model that we are accustomed to, obviously here in America, and then in the UK and parts of Europe and Australia. Then there's the Franco-German model that is used in most of Europe. Now the difference between these two, the Franco-German model and the Anglo-American model, is really treatment. Where are we treating patients, and what is our response level? So here in the U.S., if you go over to Australia, if you go over to the U.K., we're not doing a large amount of treatment on scene. Typically, what is said is we're bringing the patient to the physician. We're going out and we're going to the patient, stabilizing the patient, and bringing the patient to the physician. So we have paramedics out there with some sort of physician oversight and transporting to the emergency department. In the Franco-German model, if you go to France, if you go to Germany, go to large swaths of Europe, these patients are typically treated on scene and left on scene. So in the Franco-German model, typically what we're doing, instead of bringing the patient to the physician, we're bringing the physician to the patient. And the paramedic in these models acts as an assistant to the physician. So a medical doctor goes out there, and so in Germany, a medical doctor goes out with a paramedic. Paramedic kind of does what the doctor says. They treat the patient on scene, and there's very little, proportionally very little, transport to an emergency department. So the ambulance services are seen more as a public health service. So I've got some nausea, some vomiting, I don't feel well, I'm going to call for an ambulance, and I'm in France. Well, a physician's going to show up, treat me, maybe give me some Zofran, and refer me to my primary care physician in the morning, and I'm not going to be transported to the hospital. Whereas in the U.S., I call you for nausea, vomiting. You're going to come out as a paramedic, treat me with some Zofran, and probably take me to the hospital if I so desire. As always, if you have any questions, comments, concerns, or cuss words, please let us know.